So my name is Nathan Mulure. I'm the cluster head for Novartis Social Business, based in Kenya, Nairobi, and I'm very pleased to be here today, one of the last sessions of the CCIH conference. We are happy as Novartis to partner with CCIH. So I'll just briefly describe what Novartis Social Business entails. Novartis in itself is a pharmaceutical company that is based in Basel, Switzerland, with a global presence in over 140 countries in the world. And our operations basically cover a lot of disease areas. In Africa, it is mostly the program for malaria that has been very active. But recently, we are also venturing into the NCD space, where we're looking at provision of medicines for breast cancer, for diabetes, for hypertension, and for asthma, at a cost that sometimes shocks many people. When I tell people it's $1 per month of treatment, they fall off their chairs. But that's what we are doing as Novartis. And very much happy to partner with the FBOs. I think for us, it's a new ground to work with the FBOs. Many times we've been working with the medical associations and the universities, but FBOs is a new growth path for us. And luckily in Africa, FBOs provide about 40% of the healthcare in the countries. So we are quite happy to reach more patients through the FBOs. And we have quite a number of examples that we are going to talk about in the panel discussion. So our main disease focus is NCDs, malaria, and also what we call Healthy Families. Healthy Families is a program that we started 10 years ago in India. It's called Arogya Parivar in India, for those who speak Gujarati. It basically entails going into the communities and speaking about diseases, be it hypertension, HIV, or malaria, and educating the public on how to prevent diseases from getting into their space. So over the last 10 years, we've been able to reach 40 million people, both in India and in Kenya, through this Arogya Parivar or Healthy Family initiative. We also have what is called SMS for Life. SMS for Life is a logistical software that Novartis developed together with the Global Fund and Rollback Malaria Program to ensure that there are no stockouts in the facilities at the village level. This was launched in 2009 and has been very successful in locating stock levels at various facilities. Basically what happens is that each week or each Thursday, the health facility receives an SMS asking, what drugs do you have in these categories? So there are 4 drugs for the malaria program. And the SMS is sent back to the central warehouse, and data is collected such that the program manager of malaria program in the country is able to see which facility is in the red and which is in the green. And by having that sort of overview, they're able to shift medicines within the country to ensure that stockouts are reduced. When this was done in Tanzania about 5 years ago, the stockout levels reduced by over 75% within 1 year. So it was quite successful in terms of giving visibility to the government to reduce stock out in the facilities. So we're happy to partner with the CCIH and also FBOs. I must say that partnership is not easy to partner. It's like a marriage, isn't it? Yeah, it's like a marriage. When you're getting a suitor, it's not easy to identify the right person and also walk with them through the journey of marriage. So sometimes partnerships last long, sometimes they last for a very short period of time. Yes, and sometimes there's a lot of suspicion in the partnerships. I remember many times when I go to the Ministry of Health in many countries and I tell them about our program for Novartis Social Business, the ministers fall off their chairs and ask me one question. How possible is that? What is in it for Novartis? How do you make profit? You know, they don't trust that the program actually can be sustainable at that cost of $1 per month of treatment. So in every partnership, there are challenges, and we need to see how to walk the journey as partners for us to have a sustainable and well-meaning partnership for the sake of our patients. So with me today, I have a panel that I'd like to call to this podium one by one. And I will start with, if I call you, you take the first seat. Yeah? Jonathan Kiliko from Kenya. Jonathan is the customer services head at MEDS, Mission for Essential Drug Supplies. MEDS is an FBO that is organized between CHAC and KCCB in Kenya to avail medicines to the faith-based hospitals and also in the private sector. And he'll tell us a little bit more of how he has partnered with various organizations to increase access to care for patients in Kenya and also beyond. Kiliko is a holder of PhD in business administration and also an MBA from the University of Nairobi. My second panelist is coming from Cameroon. Cameroon, we have Professor T. Professor T has been prominent in this conference and has spoken at length on various topics. He is the director of the Cameroon Baptist Convention Health Services, CBCHS. It's an FBO that is in Cameroon, comprising of 6 hospitals and more than 50 primary health care centers, and they run a distribution and procurement center at the Baptist Training School for Health Personnel. So he oversees this work of CBH, Community Baptist Convention, and works in partnership with the national government and also other intergovernmental agencies and NGOs in the healthcare sector. So thank you, Professor, for coming to the podium. And lastly, but not least, we have Judith from ADRA in Zimbabwe. She's a country director, and she holds an MSc in administration from Andrews University and an MPH from Loma Linda, born and raised in Zimbabwe. I hope you don't mind the ratio of 1 to 3 for gender. We always have a rule in Kenya that 30% of all the seats must be held by ladies, and clearly we are almost there. Yes, so she founded an organization called the Christian Development Agency, got a funding from USAID, and also working with FBOs to implement programs. They'll tell us what the organizations have done for the NCD space. As we said yesterday, NCDs are becoming a big, big problem in Africa. For a long time, we've been fighting HIV and malaria, but currently, NCD is actually very big. And data from WHO, and yesterday I was quite shocked when I asked, is there anybody here who has a friend, relative, or colleague who has had cancer? And all of you sat down. I was actually very shocked. I thought it would be a graduated sitting down from hypertension, diabetes, cancer, but it means that all of us are actually affected by NCDs. And NCDs are coming from what we are eating, from what we are doing, from how we are behaving. NCDs are actually coming, and they're knocking their way into our lives. So we must be alive to that fact and be able to put mechanisms in place to stem the rise of NCDs, because it's going to be a huge problem. In Kenya, we are estimating in the next 30 years that 60% of the deaths, 60% will be due to NCDs. And we have pockets of NCDs that are as high as 30% of diabetes, hypertension, and cancer also is on the rise. So we must do all that is possible to help us stem from NCDs. Otherwise, we are all going to perish because of NCDs. So I would like to invite my first speaker. This time I'll start with my extreme left, Dr. Kiliko, to just come and do a presentation of about 10 minutes and tell us about MEDS and how they've managed to partner with various organizations and how MEDS started. MEDS started from a very small cubicle, one-room hut. That's how MEDS started. But now it's a huge organization. So Dr. Kiliko, please, the floor is yours. The next 10 minutes. Thank you.
Thank you, Nathan. Good afternoon. Right. Today we're talking about the power of
partnerships. And I would start by saying that we are all products of partnership. If it were not for our parents, we wouldn't be here. So partnership is something that can bring out a good product. And I just want to say that MEDS is also a product of a partnership. This time, an ecumenical partnership between the Catholics on one side and the Protestants on the other side. So they came together in 1986 to start this joint procurement unit for supplying medicine and medical supplies to the mission health facilities in the country, because around that time, the government stopped funding the works of mission health facilities. So it was through an initiative of an American religious nun, went to be with the Lord, Joan Divan, from Mercy Medical Missionaries, who started off that organization from a very small room, serving about 45 health facilities with a range of products of around 50 products in a small corner. And that has grown to be an organization which really, I would say, has got functions in supply chain, also in quality assurance and capacity building activities. Here, we're now talking of an organization that is serving not only the faith-based, the mission health facilities, but also serving the public sector, the county governments, and also NGOs. There are several NGOs that are supporting mission works within the region in South Sudan, Somalia, DRC, and other neighboring countries. So MEDS fits in supplying all those countries. We have also widened the range of our products from the 45 to 1,600. These are medicine, non-farms, medical devices, and we're serving more than 3,000 corporate clients. And when I talk of corporate clients here, I mean if it is like a county government, we count that as one client. But within the county government, we have several health facilities, 200, others 100 and something. So those are the kind of clients that we are serving. We have adequate warehousing space, about 10,000 square meters in terms of space capacity. Because of being driven by quality over those 30-something years, MEDS has been pre-qualified by USA or FDA as a wholesaler, meaning anybody or any organization getting funding from the US government can procure without necessarily going through tender system. We've also gotten DG ECHO for the European funded projects. They also procure through us without much problems. And our WHO pre-qualified lab, where we are conscious about the quality of products that we are stocking, we subject them to analysis just to fight against substandard and counterfeits. Because in Africa, there are those products which you do not know the source, and sometimes you may poison patients instead of treating them. We also do a lot of pre-qualification to the manufacturers and any supplier by visiting them in those countries and carrying out audits just to be sure that we are getting items from the right place. Let me talk a bit on now the issue of the power of partnership. And here, MEDS has measured in faith to faith-based kind of partnership. I would call it private or faith-based to faith-based. And that's how CHAC is Christian Health Association of Kenya and the Kenya Conference of Catholic Bishops came together to have this partnership. We also part of EPN, Ecumenical Pharmaceutical Network, also part of East African Community Pooled Procurement, where similar organizations in East Africa have come together. We're members of ACHAP, we're members of also CCHI, we are partnering with IMA, and we also partner with health facilities. So what am I saying? There is a lot that you can benefit with this kind of partnership. MEDS has also partnered with government, that is private to public, with the national government, county government, and also the public, that is the public sector, the hospitals, in terms of supply chain, health services, and also in terms of quality assurance. There is also the partnership with secular organization, I would say, USA CDC and other bilateral organizations. The fourth one, which I want to say something about, is where we are partnering with multinational pharmaceutical companies to increase access of commodities for non-communicable diseases. And these ones, we have the likes of Novo Nordisk, AstraZeneca for hypertension. Novo is to do with diabetes, and for Novartis, which is what we're talking about here. We have products for diabetes, hypertension, breast cancer, asthma, and also other related kind of condition. This has got 5 different molecules, and a patient, the final user, pays only $2 per month for their treatment. And also, it was supported by a study which was done by Boston University just to establish the usage of those products. How have we managed to do this? MED has got a robust kind of ERP, which is 100% computerized in this digital era. We are able to track the batches. Whatever we are selling to a health facility, we can track from the supplier to the health facility. But now, after that, well, we are not able to monitor to the patient level. We also monitor expiries, meaning that within the system, we have the first to expire, first out, through barcoding. And this barcoding, we are using it at the receiving, inventory management, picking, packing, dispatching, and also at the delivery point with the client. So this information is relayed once you use that barcode. It updates our system. With all this investment, we have quite a lot attracted many pharmaceutical companies, and most of them are now asking for consignment stock, where they place their stock at our premises, and then we are able to monitor, just drawing from them. So partnership is the way to go, because without partnership, we cannot achieve. You leverage from what your partner doesn't have. Thank you very much for listening to me.
Thank you very much, Dr. Kiliko. Indeed, as you've said, partnerships are key for us to succeed in reaching out to many patients. Even a tree in the forest, if the tree is left alone and all the trees are cut and you remain with only one tree in the forest, that tree will not grow as big as you'd wish it to grow. It will die because it lacks partners in that forest. So it's important for us to continue forging partnerships, because that is really the way for us to achieve a great length of distance as we walk. So this time I'd like to invite Professor T from Cameroon, of the Cameroon Baptist Convention, to tell us more about CBC.
Good afternoon.
Professor T.
Yeah.
Yeah. Okay.
Thank you. I'm happy. I hope you can hear me from afar. I'm going to talk to you about our NCDs under the title Know Your Numbers. And it is our prevention program for NCDs in Cameroon. And before I do that, I want to introduce to you Dr. Eddie Welty and Dr. Tom Welty, who have actually been part of our team and my immediate assistants, as well as my immediate mentors in the domain of public health. We have worked together since 1999, up to date, and we keep on moving together. So I've not been given specific time, but I prepared this for 15 minutes, and I hope that it will enter in 15 minutes. The timekeeper is just telling me that it's 10 minutes. Anyway, this is the outline that I want to cover. I would like to talk just the overview of our NCDs, and then the comprehensive response that we have given to it. I will say a little bit why we are doing this, and then give a summary findings from what we did, which was like a pilot, and a few discussional points. By way of definition, which many of you already know, NCDs are diseases that are not actually transmitted from person to person. And you have them cancer, diabetes, chronic respiratory diseases, and so on. And these are responsible for about 70% of the deaths, annual deaths that we have globally, especially in third worlds, in low and medium income countries. And in Cameroon in particular, we would be given the figure 239,000 of deaths per year that occur as a result of NCDs. And most of them are not even diagnosed. They happen in the communities where people do not even know that they are suffering from these diseases. And the nature of this, again, it is a disease that the incubation period is long. It develops very slowly, quietly. You will not even know that you are developing it. And it comes from the risk factors that you see there, which include either tobacco use, inactivity, unhealthy diets, and so on. Again, that's behavioral risk factors. But you can go to the metabolic ones too, factors, which again, you will have various changes in the kind of the risk behavior that we have in developing countries. And we have things like raised blood pressure. If you have your blood pressure being raised gradually, it means you are getting into that stage of suffering from a non-communicable disease, overweight, which is both obesity, body mass index, hepatitis. You have again high blood glucose levels in the system. You know you are getting into it, or high levels of fat in the blood. You are getting into it. Again, you can have stress. Those are risk factors that we suffer from, and we gradually move into the state where we have non-communicable diseases. It seems as if this one goes by itself. The Cameroon Baptist Convention Health Services responded by starting this in 2013. We had to recognize that there is a problem. And we recognize this from our statistics that come from our hospitals. I mentioned sometime yesterday that as we gathered data from year to year, we saw that some of these diseases were coming into the first 10 leading diseases, like hypertension featured first, and then we saw that cancers were coming in. And so we had to develop a program in 2016 because we did a situation analysis in 2015 and really saw that it was becoming a problem. And in 2016, we developed the program, and it had 7 components. And then we had to have a team that was going to work on this. We appointed a focal point, appointed other doctors just to be in charge of NCDs in the main hospitals, and we created corners for NCDs where people could check themselves in the hospitals. And then in 2017, the program implementation actually took place with partners that we had to work with being brought on board. And so what is the KYN that we are talking about, and why the KYN? What is KYN? It is just an awareness that we want to create by screening, creating screening for NCDs in our system in order that those who are exposed to the risk of NCDs in their communities are informed early so that they can prevent developing the disease. And why KYN? NCDs develop very silently. And so we have now said, since they develop silently, you have to know your numbers. And the numbers are, you should know your body mass index, you should know your blood pressure, you should know your blood sugar, and you should know your waist circumference. If you know this and they are changing, you should already know that there is cause for concern. That should be the alarm that is coming on, the alarm clock, which is coming on, and you need to change your lifestyle and adjust accordingly. KYN activities, preliminary results. Now, we had to run a pilot of this, and the pilot want to recognize Novartis because they worked with us to pilot KYN activities. And there is a book here, which is our training manual, which came as a result of this. As I talk, I may forget to show you. We piloted this in 7 health districts, 5 urban and 2 rural. 182 in-person education and sensitization meetings were conducted in those 7 districts, and 67 community screening outreaches were conducted, and screening also took place at a hospital facility. The KYN activities preliminary results continue. KYN includes only apparently individuals, but however, 4,900 known hypertensive and diabetic patients were encouraged. We asked them, we know that you are already hypertensive, continue on your drugs and do not stop. Then 104 persons below the age of 15 were also included from the analysis. In all, 7,687 healthy individuals aged 15 and above were screened at least 3 of the 4 parameters, and the results were analyzed. So this is a sample size that we are going to be showing you now, how we analyze. And so on the mean age of participant was 42 years. The range was 15 to 90 years. And then the total number of males was 2,800, which was 37%. And then the results are presented per screening parameter and by sex. And the numbers of participants screened for each parameter vary. And just look at the data there. I will be giving the overweight percentage for male and female. And you see that out of 109 that we had here, 23 of them were male, and 86 were females that had the body weight with the percentages that you see there. That is, they were underweight. So the percentage was higher for females than for male that had underweight. And then for normal weight, the BMI, you will have a total of 1,609, and of that, you will see 833 were males and 786 were females. And then for overweight, we had a total of 2,620, and of that, 1,116 were males and 1,400 were females. And for obesity, those that were obese, we had a total of 3,314, and of that, 789 were males, and 2,525 were females. So overall, the difference in BMI categories among males and females differ significantly, as you can see from the figures there. And the prevalence of elevated blood pressure by sex, you can see there that for normal blood pressure, we had a total of 5,855, of which 2,147 were males, and the 3,708 were females. And you see the percentage. I think there is a problem of the percentage that is put there. So look at the absolute numbers and don't bother about the percentages, because I think there must be a problem with the percentages. They are just the same all through. Elevated blood pressure, we had a total of 1,761, and of that, 645 were males, and 1,116 were females. So the total is there, gives you the total of the 7,000 sample that we had there. And then a prevalence of elevated, okay, I will just rush to the end so that you can at least see, as I'm going, you will see the comparison. We also look at other countries where these studies have been done, even other studies still in Cameroon, to see how our percentages compare with those of other studies that were done. And we saw that some are very similar, some are a little bit different, just to tell you that our findings are actually valid, because some are very close to what we found in terms of elevated blood pressure or body mass index and so on. And in summary, the comparative studies that we have actually show that obesity is on the increase and is going to continue to increase in Cameroon, as well as even the blood pressures is also showing that it's going to be on an increase over time. Even body weight is showing that it is increasing. So we also saw that pregnancy seemed to suggest that when women are pregnant, they gain weight. I mean, it may not be a surprise to anybody, but it's just something for us to know. Then transition from rural areas to the cities also, it was a factor that showed that when people move into the cities, because this study was done mostly in the cities, and it showed that people living in the cities actually have higher body weight, higher BPs for the worries that they may have in the community, in the cities, and so on. So in conclusion, the high rates of obesity among both men and women are of great concern to us, and I think that they merit further studies, and many of us need to know that this is a concern already. The data, again, the database can be used to justify community-based programs to address problems that are identified. Again, we believe that as less than 2% of participants were underweight, indicating that malnutrition is not a problem in our country or in some of these countries. So people rather eat more than they should be eating. So the partners that we have been working with are Novartis, and as I said, this pilot that I'm giving you the results, it was Novartis that actually funded it, and we went through the regions to do the study, and we have the program that we are using for training people in those 7 districts, as well as in our health facilities, on how to target NCDs in the communities. Again, partnership is emphasized as we work. We are not only working with our organization, we are working with the Catholics, the Presbyterian, everybody, to ensure that at least we share these lessons with them, so that together we can overcome the problem of NCDs, which have become a problem in the country. Various strategies have been put in place, and also for treatments, we are still using Novartis to receive medicines for hypertension and for cancers and so on. And we hope to increase our relationship with Novartis with time. Thank you.
Thank you very much, Professor T. I know many people are afraid of knowing their numbers. Yeah, when you tell someone to know your number, people freak out. You know, even going for a blood sugar test or a blood pressure, we're afraid of doing that, of just knowing your numbers. So it would be nice to hear more from Professor T, how they've managed to convince people to really want to know their numbers. At this point in time, I'd invite the icing on the cake, Judith from ADRA, to tell us what ADRA plans to do in Zimbabwe in the NCD space. Thank you.
Good afternoon, everyone. Okay, I know this is the last presentation and you are all kind of tired, but thank you for the smiles. It has been a privilege for me to be here. This is my first time to attend the CCIH, and I've been enriched by the connections that I've made, by the spirit with the people that are around here. What I'm going to share is mainly just experiences around NCDs, mainly moving, not really moving as such, but our experience with HIV and how it's informing our work with non-communicable diseases in ADRA. Maybe let me start by saying, okay, I'm from Zimbabwe. I work in Zimbabwe. I work with ADRA. ADRA stands for Adventist Development and Relief Agents. It's a non-governmental organization for the Adventist Church. Is present in over 120 countries of the world. In our work that we do, we are inspired by our Christian values, and it felt so good just to be in this room, to be sitting with people who have similar values. The church has a duty for proclaiming God's word, but they do it more by their presence in the community. So seeking the health and well-being of those around us is part of proclaiming the good news. Our health message loses its power if it is separated from the gospel message. 3 John 1 verse 2 says, "Beloved, I pray that in every way you may prosper and enjoy good health, as your soul also prospers." So health principles may yield a few years of additional life, but our mission is to teach and demonstrate the power to change that comes from Jesus. So as ADRA, our programming is around 3 areas. We have education, we have health, and we have livelihoods. Central to that is well-being. So well-being is really, so health it cuts across everything that we do. And we also do emergency work. But even as we do that emergency work, central to that emergency work, again, is the well-being. And the purpose statement for ADRA is serving humanity so all may live as God intended. So it's just out there, it's just plain, that's what we do. And our motto is justice, compassion, and love. And the way we work is that ADRA works with people in poverty and distress to bring about positive transformation through empowering partnerships and responsible action. So partnerships are very central to the work that we do. One morning, I received a call from a government official, and this government official is the Deputy Director for Non-Communicable Diseases in Zimbabwe, in Department of Non-Communicable Diseases in Zimbabwe, in the Ministry of Health. And he said, "Judith, can you please give me the numbers again for the biggest health expo that took place in 2015, which was held by the Seventh-day Adventist Church?" And I said, "Sir, in order to help you better, what do you need the data for?" And he says, "Well, this is the biggest event around non-communicable diseases that has happened in the country, and it was led by the church, and we want to report it because that's our biggest event as a government." So it was interesting that something that was done by the church was now being recognized as part of the key work that the government did. Before I get to that, let me just say that ADRA has worked across faiths over the HIV pandemic. And this experience is actually informing the way that we are working with non-communicable diseases. I don't want to labor you with the reasons why churches are very critical in disease prevention, control, and management, because that has been said over and over again. So what is it that is that we have learned from the HIV pandemic that is informing our programming in non-communicable diseases? There is a dual burden of HIV and NCDs. If you are working in the space of HIV, you may as well start working in the space of non-communicable diseases. There's a recent study that was done in Zimbabwe, which shows that let me put it across this way, which was done for 2015, which shows that 33% of people who are living with HIV are likely to suffer from one or two non-communicable diseases, as compared to 14% of those people who are not living with HIV. And then they did a projection up to 2035, and the numbers become scary. 59% of people living with HIV will be having one or more NCDs, whilst those with no HIV will be on 21%. Still, the figures are staggering. And if we look at that, the main NCDs that people with HIV are having problems with is, hypertension, diabetes, kidney failure, depression, and just study shows if ever you've been diagnosed with any cancer. And the cancers are mainly cervical cancer and breast cancer, and you can see the burden that it already has on women. So church's response, the main response, the program that the deputy director was talking about was a program which was run in 2015, and it saw through 27,000 people who went through screening. And it was a 2-week event whereby there were different stations from nutrition, mental health, drug rehabilitation, and various stations that were put in an area called Chitungwiza. And in the evening, then there will be preaching that was taking place, but during the day, people would come. The main thing that was amazing about that program is that over 500 health professionals were part of that exercise. This was not funded with any funding from outside. This was funded from funds from the communities, from the members who are in Zimbabwe. And the volunteers came from churches, not only the Adventist church, but across. So it means the people who are sitting in the pews, that's where you have the doctors, you have the nurses, you have the mental health specialists. So we have strong resources from within community that can be used to combat this non-communicable disease pandemic that we are actually getting into. But well, as you know, with non-communicable disease, it's not about an event. It's really a process. And so after 2015, people started to continue with the program as churches. And in this case now, they were using a program called Celebrations. Celebrations, it's an acronym. It's a program by the Seventh-day Adventist Church. Celebrations, if we have time, we'll talk more about it, but this is based on health principles. If you go and Google, it's there and it's free for everyone to use. It stands for, to help me now that I am ending, you can spell celebration. If you say C, I tell you what it stands for. Okay, so let's start so that I'm not alone in this. Okay. C. It stands for choices. E. Exercise. L. Liquids. E. Environment. B. Belief. R. Rest. A. Air. What do you call it? Air. I don't know. My accent is air. Oh. Okay, my mother tongue influence. That's okay. Okay, where are we now? T. Temperance. Integrity. Optimism. Nutrition. It's celebrations. Social support and services. So with all that, you have lessons that you can go through, and it brings about awareness. So the celebrations also comes with the following promises. The promises are the choices are yours to make, and we honor your individual rights and responsibility. Because it was designed by the Adventist Church, the Seventh-day Adventist Church believe in a creator God and will speak openly and sensitively of this belief as a group. We are some of the world's strongest believers in religious freedom, and we will not seek to coerce, but to show the joy of embracing a healthful lifestyle. We will seek at all times to present scientifically supported material that will embrace we seek at all times to present scientifically supported material that will enhance the quality of your life. So you are free to download it and to follow what it says. I just want to say that let me go to the conclusion, since I'm looking at the yellow card. There are challenges and barriers and opportunities. Maybe during the time during the question time, I can elaborate on the challenges, on the barriers, and on the opportunities. But let me conclude by saying the work on prevention and control of NCDs is a process and not an event. As such, commitment to building long-term relationships, collaborations, and partnerships is vital in the response. Offering accurate, evidence-based health programs builds confidence of the communities and makes it easier to monitor, evaluate, and feed data into the national health system. As Christian communities, we should not shy away from our passion to share the power of Christ, His word, and prayer as the only agents of permanent change. Thank you very much.
Thank you very much, Judith, for that wonderful expose, and thank you for all the speakers for telling us what your organizations are doing. I think for us the message is clear. If we are not treating our patients, somebody else is, isn't it? If you're not treating our patients as Christians, then somebody else will treat those patients. If there's no meds facility in your country, or meds-like facility in your country, then somebody else is actually providing those drugs in that space. So we must, as Christians, take our rightful place. There are about 2 or 3 billion Christians in the world. And I think through our faith-based organizations, if we aim to reach 60-70%, we'll have done great service for the Christians in our communities. So right now, I'd like to go to the Q&A session. I'm aware of the time. We started half an hour late for this plenary, but I wouldn't want to demand the 30 minutes that we lost, but we'll have to wrap up very fast. So first of all, just like to ask one round of questions, and then I'll open the floor to everyone else so that we can finish. At least by 4 p.m. we should have wrapped up. So my first question goes to Dr. Jonathan Kiliko.
Who has a question? Can you please introduce?
Okay.
Yeah, I'm Debbie from World Relief, and I've known Jonathan a long time, and very, very excited to see you there, Jonathan. But my question for you is, with the discussion about ARTs moving much more to either fee-based or government paid supply chain, how do you envision that working in Kenya?
I don't know where the other microphone went.
Thank you, Debbie, for that question. Well, yes, the distribution of HIV products, especially the ARVs, are being distributed through the public sector. But before then, Chemonics was handling the supply chain. But after transitioning to the national procurement entity, which is the Kenya Medical Drugs and Supplies Authority, we are experiencing gaps in terms of the supply chain. And what we've been always pushing for is it possible through, again, the USAID funding to have like parallel sort of distribution where the faith-based usually have to refer their patients to the public sector because there is very little that has to go around for both the public and the faith-based. So yes, we are having problems. MEDS was the first one to start distribution of ARTs to both the public and also the private at that time. Thank you.
So we can do a round of questions and then we answer them together. So one round of questions. So next person who has an issue or question or comment. Yeah, as we look for the questions, I'd like to ask Jonathan a question. If somebody in Liberia, for example, Patricia, the head of CHAL in Liberia, would like to start a facility in Liberia, just the same blueprint that MEDS followed, what kind of advice would you give her to have this in place?
Patricia, I would take time to first encourage them. I don't know whether people on that other side are hearing. Whether first is to encourage them, allow me just to start. It's first to encourage them to have a buy-in from the religious leaders. Let all of them see that there is a mission. The Great Commission is calling them to do something for the patient, many patients who are in that country. And then they come up with a framework on how they are going to relate to each other. So interdenominational kind of arrangement. A lot of also to do with benchmarking by visiting countries with similar organization. But in the meantime, as you do all that, yeah, we still can extend these services to other countries. Already we do serve countries in West and also in the Central Africa. So you can always now have that as you learn through those who have already done it to avoid mistakes that organizations like MEDS meant, then that can be a journey that we can work together. But in the meantime, the supplies would be there, including even to organizations like ADRA in Zimbabwe, if they had sort of like a network within which you can procure big quantities and then in country you do the distribution. Thank you.
Thank you for asking my question. I'm Patricia Kamara from CHAL in Liberia. Now, we have already started the drug revolving program, and we are now supplying up to 40 health facilities with medicine and medical supplies. And I was happy when I met him and we had this discussion. So I just wanted to know how we could go about it. But now that you have explained, I'll make sure to follow up.
Okay, as the next question comes, I would like to ask Professor T of CBC. Thank you very much again for the expose about CBC. I'd just like to find out from you the role of the community in partnering with the community for NCDs, NCDs. Do you think it's a viable path to take in terms of including the community to help us know the numbers and fight NCDs? And what would you think also of community-based health insurance? Is it something that Cameroon is looking at?
Partnering with the community is the way to go because, as you saw from the presentation, we say about 70% of these cases are in the community and some of them are not even diagnosed. And therefore, we need to go into the community, partner with them using the local chiefs, talk with the chiefs to actually incorporate this in the local meetings. They have meeting houses, social groups, and so on. They need to talk about about NCDs in all gatherings in the community. And churches are also part of the community, part of the civil society. And we need to let them even give these messages from their pulpits every Sunday. And talking about insurance, we do not have one in sight in Cameroon. We have some mutual health organizations and so on. but they actually do exclude NCDs. They don't include, when you register, they actually exclude some of these terminal diseases from the insurance when you register. We don't have.
Thank you, Professor, for that response. So lastly, I'd like to ask, is there any other question from the congregation? No other questions? I'd like to ask, you have a question? Okay.
So I ask this question a lot in sessions. A lot of folks that come to CCIH are concerned about monitoring and evaluating their programs. So Judith and Pius, this question is for you. Do you have tools you currently use for M&E that you'd be willing to share with other people in the CCIH network?
Yes, at first we were using just simple Excel spreadsheet, but now we have developed what we call DAMA. DAMA is data manager, which you can enter data and you will see it as you are. You can generate any kind of report using the DAMA. And it is very simple. Any person can use it. So you may want to get more information from me or from our service at any time. It was PEPFAR that helped us by giving us funds to develop DAMA. We were hoping that more churches in Cameroon and the government, the Ministry of Health, is already using it. So it's a very good software.
Judith, you have some response also on your M&E for ADRA programs?
For ADRA programs in general also.
What you did for Zimbabwe? Yeah.
For ADRA programs in general, we have quite some robust M&E methodologies that we use for different programs. But for our NCDs, I have to be open and say we haven't quite come up with a suitable M&E program because we are in the initial stages of the NCD.
Yeah, so thank you. Because of time, I saw the yellow card. Before it goes to red, I think I should wrap up here. And I'd like to take this opportunity at this time to thank our panelists for the incredible work they have done in their countries and the exposure that they've given us. I think for us, it's a learning that we can pick from what they have portrayed here and what is really working. That's what we want to work with. So a round of applause for our panelists.